Hi, I'm Dr. Carleigh Nesbit. I'm a reproductive endocrinology and infertility specialist at Boston IVF. I'm in the Bedford, New Hampshire office. I'm one of the most new docs in Boston IVF. I just started about 6 months ago, but really looking forward to answering your questions tonight. And please feel free to write in anything, and I'll do my best to answer. There were a couple questions that had come in advance, so I'm gonna just start with those, but as more come in, I'll get to them. But the first question is, how long does an IVF process take? And the answer is it really depends. So the short answer is that typically during IVF, a patient takes injectable medicines for 10 to 14 days. And the exact number is really dependent on how the individual person responds to the medications. We can take our best guess, but sometimes people take a little longer or go a little quicker than we expect. The patient's then scheduled for an egg retrieval, where the eggs are removed from the body in a minimally invasive procedure. And then there are kind of two options. So if the patient's freezing eggs, then the process is over there. The eggs that are removed are frozen. If the patient is making embryos with a partner or donor, then the egg and sperm are put together, grown in the lab for somewhere between 3 and 7 days, and then either put back into the patient to try to achieve a pregnancy, or the embryos are frozen. And if someone's doing genetic testing on embryos, that can take a little longer because it can take a couple weeks for those to come back. So without genetic testing, from start of taking medications to knowing if you're pregnant or not is about a month. With genetic testing, from start of taking medications to knowing if you're pregnant or not could be closer to 2 or 3 months. Sometimes the process takes a little longer too, like, if you're coming into the office for the very first time and haven't had any evaluation, that can take some time, usually a month or 2 for us to complete. And then in New Hampshire, which we're really fortunate to have most of our patients have some insurance coverage, it can take another month or 2 for us to make sure that we get your cycle covered for you. So the short answer is, 3 to 4 weeks. The long answer is it can take a couple months. The next question I had was, after a successful pregnancy, how quickly can one do another transfer of a frozen embryo? And that's a fabulous question. There's some data out there that pregnancies that are too close together can be more risky. And we don't have like a magic number of what's safe and what's not, but typically, having pregnancies that happen within 6 months of delivery are thought to be the highest risk. And really, the safest is if you wait 18 months from, at least 18 months from the time of delivery to when you become pregnant again. I'd say that most fertility doctors won't want to transfer an embryo sooner than 6 to 9 months at the very least after you've had a baby. The next question I have is from, it says, I have endometriosis and I'm 35 years old. How long should we try to get pregnant before reaching out for help? So a lot of people have heard that if a couple with the female patient under age 35 are trying to get pregnant, that they should try for at least a year before they seek out help. And if the female patient is over 35, that they should try for, no longer than 6 months before they reach out for help. But I kind of think that goes out the window if you have risk factors for infertility. And one of those is endometriosis. So I would so much rather, as a fertility doc, see people sooner rather than later. It breaks my heart when somebody tells me I've been trying for 5 years and I don't think I've ovulated once. I'm like, where were you 5 years ago? I would have loved to talk to you. So to answer your question about endometriosis, that can definitely make it more challenging to become pregnant. So it wouldn't be wrong to seek some part of evaluation sooner rather than later, especially if you have severe endometriosis. And some of the things I think about in those patients are like, are their tubes open? Should we at least check out the fallopian tubes or an ultrasound to see how severe the endometriosis is before we give you an amount of time to try at home on your own. So I think talk to your doctor sooner rather than later, and it may make sense to check some things out, even if you've just started trying to get pregnant. The next one I have is, as somebody with unexplained infertility, what should I be getting tested that I could ask my doctor? So I would presume this person has had some testing already, because if you've been told you have unexplained infertility, that generally means you've had some testing and the results have come back normal. But the sort of initial infertility evaluation steps are typically doing some assessment of ovarian reserve for the female patient. And that can include a combination of blood work and ultrasound. Also checking out the uterine cavity and fallopian tubes. And there's a couple different studies out there that, that we can use to do that. One's called an HSG or hysterosalpingogram, and that's an X-ray test. And the other is called a HyCoSy, which is a water and ultrasound test. The other part of the kind of initial evaluation is a sperm test if you have a male partner, where we look at multiple aspects of the sperm. And those are kind of like the bare bones fertility workup. But if your doctor hasn't already done this, you should also have a preconception workup, because the goal is to get you pregnant, right? So, you know, a standard set of prenatal labs. So making sure your blood count's normal, that you don't have anemia, that we know what your blood type is, that you're immune to certain viruses that can be harmful in pregnancy, like rubella and chickenpox. There's also options for some genetic screening prior to pregnancy called carrier screening. And anyone who's thinking about getting pregnant should talk to their doctor about those options. So those are just some of the things that I notice sometimes get missed in the workup, because we get the blinders on and we want to figure out why someone's having trouble getting pregnant. But it's important to make sure people are safe and healthy before pregnancy too. I have another question, which is, could you talk a bit about the process with a partner who has had a vasectomy? We are considering IVF versus vasectomy reversal. That's a fabulous question. So men who have had a vasectomy have more limited options in terms of ways to try to get pregnant. There's kind of two main ways to go about this. One is to try to reverse the vasectomy. So basically, this is usually done by a reproductive urologist, and they go in and they basically cut out the scarred part of the vas deferens that was scarred as part of the vasectomy, and they do microscopic surgery to put it back together. So it's a really complex surgery, but that option can be wonderful for the right patient, because you may not need any other fertility treatments. You may be able to conceive by timed intercourse at home. Some men will elect instead to have a surgical sperm retrieval, because usually for a lot of men, sperm production is still okay. It's just there's no way for the sperm to get out. And so sperm can be surgically retrieved. The downside of that is that then our only option to use that sperm is to do IVF. And so that's something that's important to know when you're weighing your options, that surgical sperm really can only be used in an IVF process, and that involves a lot for the female partner. Some urologists will do both at the same time. So they'll offer to surgically retrieve sperm at the time of vasectomy reversal. And that can be a nice option because just in case we're not able to get sperm to come back in the ejaculate, or if it comes back, but then that scarring reoccludes, then you have a backup option. So that's kind of the very basics of what options are out there for these couples. Next question I have is, how important is PGT? It says GPT testing, but I'm going to assume that means PGT testing. And what PGT testing means is it stands for pre-implantation genetic testing. And what that means is testing of an embryo before it is put into the patient to try to make pregnancy. And to answer this question, I think we have to dive into like what are the different types of pre-implantation genetic testing. So there's kind of three main different types. The most common that you'll hear about is PGT-A, or pre-implantation genetic testing for aneuploidy. And what aneuploidy means is an incorrect amount of genetic material. So either too much or too little genetic material. We should have 2 copies of every single gene, one from our mom, one from our dad. But some embryos don't have that. They have extra or missing copies of genes. And when that happens, usually you just wouldn't become pregnant from transferring that embryo. Or another possibility is having an early pregnancy loss. And we actually think that's like the most common cause of pregnancy loss overall for all patients. Some of those things too can go to term, like Down syndrome is an extra copy of chromosome 21. Turner syndrome is a missing copy of the X chromosome. And so PGT-A is basically screening for those things. And so the patients where I really will recommend PGT-A are particularly patients who are in their later 30s and early 40s, because they are more likely to have embryos with aneuploidy or with an incorrect amount of genetic material. But it's reasonable for any patient to consider that testing if they'd like to do that, and your doctor can really have a nuanced conversation with you about if it makes sense for you to do or not. One thing that's really important to clarify about it is we can't change the genetics of the embryo. So if you have 4 embryos, the embryos are what they are. They're normal or they're not. And so some patients will say, I want to let nature or my body tell me, and let's put back the embryos and give them a shot. And, most likely if they're not normal, I would, not get pregnant or have a very early loss. And some people want that added layer of information about their embryos and opt to have testing done. Just really briefly, there's 2 other types of PGT testing. One's called PGT-M, and the M stands for monogenic disorders. And we talk about that less often. That's really for people who have identified that they are at risk of having a child with a genetic disease due to a point mutation. So I think of it like a typo in a gene. And so some examples of that are like couples who are both carriers for cystic fibrosis or Tay-Sachs disease, or sometimes it's adult onset things like cancer syndromes or Huntington's disease. And we can actually test embryos for those things too, but it's a little bit of a different test. And the last one is called PGT-SR, or PGT testing for structural rearrangements. Those, that's a really specific test for individuals who have their own DNA rearranged in a different way, and puts them at a higher risk of pregnancy loss. So most patients that I'm seeing in the office, I'm talking to about PGT-A, but there are other types of testing too. I have another question here that says, is my doctor going to do my egg retrieval? So, I think it depends on your practice model. So, in my practice model here in New Hampshire, it's me and one other physician, Dr. Wright. And so any procedure that you would have done, it would be one of us doing that. Whereas in our other offices, some of them have larger groups of physicians that do procedures there. And some of them are like our office, where it's a pretty small group of physicians doing procedures. But it's kind of a nice thing for our patients because they know that any egg retrieval or embryo transfer that they're going to have done is going to be one of two people. But it really depends on your office and their style of practice. So I have another question from Kate that is, we are doing a third embryo transfer on Monday after 2 failed embryo transfers last year. What can I do differently before and after the transfer? Well, first off, I want to wish you the best of luck. Third time's the charm. I'm so sorry those other 2 transfers were not successful. My thoughts are that there's so little of this that we get the opportunity to control. And so my best guess is that you did everything you could with those past 2 transfers, and you're doing everything that you possibly can with this one too. These are kind of old wives' tales or superstitions, but when I, in a practice I used to work in, one of my favorite IVF nurses would tell every patient who was having a transfer that they should eat something salty, keep their feet warm, and do something that makes them laugh. So in a situation where you can't control much, and maybe that's voodoo, but I like that, and I think those are nice things to do for yourself anyway. But there's no known practices that you can do afterward that are going to make or break your success. So some people feel like they should rest there or before they stand up. The embryo is not going to fall out. Some people feel like they should take it easy for the rest of the day, and it's really whatever feels right to you. But there's part of it that's just accepting that a lot of it is out of our control, and so you just got to be kind to yourself too, because my best guess is you're probably doing everything right already. Next question is, how important is lining thickness getting ready for a transfer? If a patient is struggling to thicken their lining, is there an underlying cause? That's a fabulous question. So lining thickness, we think, is pretty important in terms of chances of success with a transfer. And sometimes we will cancel cycles where we can't get the lining thick enough. A little more nuance to that answer is we don't know like the exact cutoff where transfer is more likely to work or less likely to work. Most of the literature we have suggests that having a lining that's at least 7 millimeters is a good thing. But there's some emerging data that linings that are thinner, as long as they otherwise appear normal, might be okay too. In terms of causes for it, some people do just better with different protocols. So or different formulations of medications. So some people do better with oral forms of medications than transdermal or vaginal or one or the other. Some patients need more medication or longer duration of medication to get a thick enough lining. And some people just do better with a totally different protocol. Like some people might have trouble building a lining with a medicated cycle, but if they do a modified natural cycle or a natural cycle, they might be able to get a thicker lining. When I have a patient where I'm having a really hard time getting their lining thick enough, there's a couple things I think about. The first is there something going on in the uterus that's causing this? And some of the big culprits are something called Asherman syndrome, which is scarring in the uterus. That can make it really hard to build a lining. And the other is something called chronic endometritis, which is kind of a chronic inflammation of the lining of the uterus. And that one can be sneaky because a lot of times people don't have other symptoms of that. So for those patients, I'll do a uterine cavity evaluation, either with a sonohysterogram or a hysteroscopy, and I'll do an endometrial biopsy to make sure that they don't have chronic endometritis. But if I've done all that and it's all normal, sometimes I try something different and sometimes that does the trick. The next one is, do you have any recommendations for how our partners can best support us while preparing for and going through IVF? I love that question. I think it's really hard to be a partner too in this process because, usually the person that's going through the ovarian stimulation and procedures is like kind of the star of the show, right? And sometimes the partner will feel like, oh, my partner's going through all this stuff, like I'm not contributing enough. It's maybe because of me that my partner has, to go through these things. But I try to reassure our partners that they're really important too. And I think the biggest things are them understanding the process and just being there for you. And that might be giving you injections, that might be, driving you to and from appointments, or it might just be being there to listen to you and support you through this. Because, the person who's going through this really is taking the brunt of this process. So, my hope is that is from a partner and they're looking for how best they can be the best partner possible. But I think just being there and listening and doing whatever they can, whatever works best for the partnership. So I have here, is any medication given to improve the chances of implantation? So that's a good question. It really depends on what sort of treatment you're going through, and depends on the very specific scenario. It's a little hard to know, like, if you're doing IVF, some of the most important things in improving the odds of implantation are your hormone levels and making sure those are appropriate. And sometimes in an IVF cycle, your doctor may recommend not doing a transfer right away because of an abnormal hormone profile. But it's, not so much just any medication, but the timing of the medications is really critical. And so that's a great question to ask your doctor. Like, is there anything else I can be thinking of in terms of medications or the medications I'm already on to maximize my chances of success? The next one that I have says that I'm 31 and I've had 5 failed embryo transfers. The embryos were AA, or in case others aren't aware, that means a very nice quality embryo, and were genetically normal. What else can I and my partner do to improve our chances of success? / what can I do to improve egg and embryo quality? That's a fabulous question, and I'm so sorry that has been happening for you. It's really challenging when you have these beautiful embryos and you know that they're genetically normal and you're still not able to get pregnant, because it feels like it should be in the bag, right? So when I have patients like this, there's a couple things that I think of. The first one is, there's this thing called chronic endometritis, and it is it's sort of a hot topic, and it's an evolving topic, but that's something that I test my patients for, if they've failed, either transfer of multiple good quality embryos or sometimes even if they've failed even just one transfer of a genetically normal embryo, and that's screened for by an endometrial biopsy. The other thing is that I often check people who have had multiple failed embryo transfers. I check their fallopian tubes again, and it seems silly because you don't need your fallopian tubes in IVF because the egg and sperm meet outside the body. But there's some data that people who have blocked tubes that are full of fluid can have a harder time getting pregnant, even with beautiful, perfect, genetically normal embryos. And so when I see a picture like this, I often will do a hysterosalpingogram to check out the tubes. And I never think I'm going to find anything. And I find these blocked fallopian tubes all the time. And then, the recommendation is to surgically remove them through a minimally invasive procedure. And I've had a lot of people who weren't getting pregnant from really nice embryos get pregnant after that. There's some other things out there you may hear about, something called an endometrial receptivity assay. That is a test that is basically assessing if the timing of your embryo transfers has been appropriate. There's a lot of conflicting data about that test. And there was a time where, people were really excited about it as a way to improve outcomes, and it's fallen out of favor a little bit, but some doctors will still do it when somebody's had a bunch of failed transfers and we can't figure out why. There's also some emerging data too about treatments for people with recurrent implantation failure. And some of that is empirically treating undiagnosed endometriosis or adenomyosis with things like Lupron and letrozole. So sometimes I think about that too, of especially if I think the patient has those things, pre-treating them for a couple months with that before we do a transfer. But I hope that helps, and I'm going to be sending you lots of good thoughts and hopefully the next one is the one. So I have another question, which is, I had a chemical pregnancy and I haven't had my period in over 4 weeks. Is that normal? That's a fabulous question. So it can be anytime after a pregnancy loss, it can take a little longer for things to get back to normal. And it depends on the person. If somebody has irregular cycles before they have a pregnancy loss, they might continue to have irregular cycles afterward. But I'd say if you go another week or two and you still don't get your period, I mean, absolutely check a pregnancy test, because, it could be that you've gotten pregnant again right away. But if it's negative, I'd reach out to your doctor, because sometimes they can check some hormone levels and try to figure out what might be going on. Okay, the next one I have is, can you speak on PGT IVF? I specifically am looking to do IVF to hopefully remove the celiac gene. I have celiac, my partner does not, but has one of the genes. Is it a common request, and do you have a geneticist on site? Great question. So Boston IVF does have a team of really incredible genetic counselors, and I rely on them heavily for questions like this. But some chronic medical conditions like celiac, one I get a lot is like type 1 diabetes. Other ones are like breast cancer, where there may not be just one gene that's contributing to the disease process. And that gets really complicated. There is this thing called polygenic risk scoring, and it's something that you might see come up when you're looking at IVF and researching, but it's basically trying to assess the risk of an individual or of an embryo of having a certain disease that has a complex inheritance pattern. And there are evolving platforms to test for those things in embryos. But sort of my personal opinion is we're not quite there with that yet. And it can get really complicated, because you can imagine a world where we could say about an embryo, oh, this embryo is more likely to get breast cancer, but less likely to have heart disease. Which one do you want to transfer? And that gets really ethically complicated for both the physician and the patient. The next one I have is, when is it not a good idea to go for a fresh embryo transfer? Fabulous question. So, fresh embryo transfer, for anyone who doesn't know, is basically putting an embryo back shortly within a week of an egg retrieval. And there's basically two main reasons why one might not want to do that. The first is about patient safety. So if somebody is at high risk of ovarian hyperstimulation syndrome, so if they're like a high responder to the meds and get lots of eggs, have high estrogen levels, then the concern is that if you get that person pregnant too quickly, then basically the pregnancy wants to maintain that hopped up hormonal state. It says, I love it in here, let's keep the party going. That's not so great for the patient, though, because keeping those hormone levels super high can cause them to go into ovarian hyperstimulation syndrome, or OHSS, which, if it's a mild case, can involve just things like some bloating and not feeling well, including some nausea, but it can become really severe. Some people need hospitalization for it. Basically, the ovaries can pull fluid in around them, and that can cause, can be so severe that you can have kidney injury, liver injury, blood clots, and electrolyte problems. The problem is then if you're pregnant, like, we can't stop it, right? Like, this is a highly desired pregnancy, and we want the pregnancy to stay there, but that can be really challenging. So a couple of things are, your doctor might, during your cycle, say, hey, I know we talked about doing a fresh transfer, but I kind of want to bail on that plan because I'm worried about you. And the other possibility is your doctor might say, before you even start your cycle, they might say, wow, I think you're going to do really well in your cycle. I think we're going to get a lot of eggs. And I'm so sure about that let's just plan a freeze-all cycle from the get-go, because I don't want to put you at risk, and I can anticipate you might be at high risk. The other other possibility is not about safety, but it's about success. So those high responders also have been seen to have lower success rates with fresh transfer. And there's a couple other things. So some people will start to get progesterone levels rising too early, and that would be a reason to recommend switching to a freeze-all cycle. And the reason is because our uterus sees progesterone and thinks, oh my gosh, I ovulated, I'm going to start getting ready for an embryo to show up. And if that happens too early, then the uterus basically has gotten out of its window where the embryo can implant. And then another reason would be if something comes up with your uterine lining during the process. So that might be that you get diagnosed with a polyp that you didn't know was there, or we brought up before, the lining issue, like if you can't get your lining thick enough during the cycle, those might be reasons to recommend not doing a fresh transfer. The next question I have is, what is unexplained infertility? And so, I think somebody had brought this up earlier, that, unexplained infertility basically means that with the testing that we have available, we are not able to identify a cause of the couple's infertility. And I want to be really clear, that does not mean that there's not a cause. There is definitely a cause. It's just that we don't know how to test for it yet. And right now we tell people, I'd probably tell, 15 to 20% of my patients that we've done the full evaluation. I haven't found anything abnormal. I haven't pinpointed why you're having trouble. But that does not mean there's not a reason. And probably when we're a lot smarter and can test for a lot more things in 5, 10, 20 years, I'll only tell 5% of my patients that. one thing that's sort of interesting is when you go through fertility treatments, in particular IVF, sometimes we get an answer when we didn't have one before. So sometimes I'll have a couple with unexplained infertility, and then we do IVF and none of their eggs fertilize or none of their embryos develop. And then we've kind of found our answer, right? That, that we couldn't test or beforehand, but now we're seeing that that's what's happening inside their body and why they haven't been able to get pregnant yet. Next question is, I've heard that success rates can be better with frozen transfers as opposed to fresh transfers. Is that true? And are patients given the option for what they want? That can be true for the reasons we just talked about. There are some cases where there's a higher chance of success with a frozen transfer rather than a fresh, or it's safer to do a freeze-all cycle than a fresh transfer. I talk to all my patients about it up front, and I'll try to be clear in making a recommendation, because there's a lot of decisions to be made in IVF, and sometimes it's hard to know as the patient, what the right answer is. But it's certainly something to ask your doctor about, like, do you think I'm a good candidate for a fresh transfer, or should I consider a freeze-all cycle? Why or why not? The next question I have is, if for some reason I need to have a frozen transfer, can I choose the date of the transfer? Let's say if I do the procedure in May, can I choose to do the frozen transfer in July? Yes, usually once we have embryos frozen, we have a lot more flexibility. And usually if you want to delay for some reason, like your doctor offers to have you do a transfer next month, but you have a big trip planned, then you should absolutely go on that trip. Your embryos are not going anywhere. It depends on the protocol. Some frozen embryo transfer protocols lend themselves a little better to a very specific schedule, whereas some are less predictable. And that's something to talk to your doctor about, that if you have a very specific date range that you'd like your transfer to be, they may be able to help you with that. And sometimes we're able to use things like birth control pills to modulate when your cycle is going to fall if you do have a specific preference. The next question I have is from Anna, and it's, I recently learned there are heightened risks of twins. But I know it can be common to implant 2 eggs in an IVF cycle. What are the recommendations on this? Fabulous question. So I think a little bit of that comes from a historical perspective. So in the early days of IVF, we were not as good at embryo culture. And so when we were transferring embryos, we knew a lot less about them. So, we might have been transferring embryos that only had 4 to 8 cells, whereas now we're able to grow embryos outside the body up to a point where they have like 100 or more cells. And we're much better able to assess quality the longer that we're able to watch an embryo develop. And so it's been an evolution over time that we used to put in more than 1 embryo much more commonly, whereas now I would say the vast majority of cycles, doctors are putting in just 1 embryo. And that's because there are certainly higher risk of multiples if we put in more than 1. That being said, an embryo can split. So there's about a 1 to 2% chance of an embryo splitting, even if we just put in 1. And that has happened to me like a handful of times for my patients. So it really does happen. What is the cost of IVF treatment is the next one, and that's from Khadijah. Great question. So it really depends on if you have insurance coverage for all or part of IVF, or if you're paying out of pocket. It can also depend on what sort of IVF you're doing. So IVF with genetic testing of embryos out of pocket is significantly more expensive than without. And if you don't have insurance coverage, or you have limited insurance coverage, there's some fabulous opportunities out there for financial support, and that includes things like fertility loans and fertility grants. So when you talk to your doctor about your IVF cycle, they and their team should be able to give you a pretty good idea in terms of what sort of out-of-pocket costs you might run into. The next one is, how many embryos can one freeze? So that's a great question. And there's really not a limit in terms of, how many embryos somebody can freeze. Another question I get a lot is, how long can my embryos be frozen for? And really that's indefinitely, as far as we know. So I have a lot of couples that I talk to about, I would love to be able to build your whole family from one IVF cycle and the embryos we create from that. And that involves the patient coming back, after they have their baby 2 or 3 years later, to have another baby and even maybe a third baby down the line. And then the rest of this question is, what is the treatment for a female with genetic mutations, celiac and type 2 diabetes, and a male with low sperm motility? So, like we talked about, if a couple is at risk of having a child with genetic disease, the only way that we can prevent that is by doing IVF and testing embryos outside the body before they're put into the patient to try to achieve a pregnancy. In terms of the question about low sperm motility, it kind of depends on how severe it is. If a man has, mild sperm problems, then something like intrauterine insemination or IUI might be effective. But if it's a severe problem, usually IVF is recommended, as that's more effective at addressing those issues. And then in terms of chronic medical conditions like celiac and type 2 diabetes, ideally, one of the biggest things you can do to optimize your success is to have those conditions optimally managed before you do IVF and become pregnant. And that's something that we work cooperatively with our patients' other subspecialists, like their primary care doctors, their gastroenterologists, their endocrinologists, to optimize patient health before pregnancy. Next question is a sonohysterogram required for each fresh or frozen embryo transfer? And at least in my practice, no. So, if somebody has had a normal sonohysterogram within a year, then that they don't necessarily have to do one, before every single transfer. I do like to repeat it if somebody has a pregnancy loss, because I want to make sure that, there's no retained pregnancy tissue there, or no new scar tissue there that could compromise success in a future transfer. Next one is for a couple with sickle cell carrier and who are trying to avoid an embryo with sickle cell disease. What are the best options? So sickle cell disease is a recessive genetic mutation, and the optimal treatment, the option we have that's a treatment for that, is IVF with PGT-M or pre-implantation genetic testing for monogenic disorders. Basically, what will happen is or your fertility doctor would work with a specialized lab to actually build a test for your specific mutation, and then be able to test embryos for the mutation before they're put back into the body. Next one I have is from Teresa that says, would Boston IVF be able to test me to see if I can get pregnant? Great question. So there's no one test that can tell us if someone is or is not able to get pregnant. If you've been trying to get pregnant and have not been successful, or you're worried about your ability to become pregnant, that can certainly start with a fertility doctor like we have at Boston IVF, but a lot of people will start with their primary care doctors or their OBGYNs, and often, they can help get the ball rolling on these things too. But we're really all here to help, sometimes I see people from the get-go where I'm ordering their very initial tests, and sometimes I'm seeing people who have had a really thorough workup with their primary care doctor or their gynecologist, and maybe have even done some treatment with those folks, and then are coming to see me because they haven't been successful. Okay, the next one is I was recently diagnosed with very high cholesterol levels and an A1C that puts me in the pre-diabetes range. My OBGYN has told me that I can work to improve my numbers with lifestyle changes for now and metformin, but will these issues cause problems with IVF? Excellent question. And the answer is they can. There's some concerns about insulin resistance and diabetes in terms of egg and embryo quality. One thing I want to say though is that lifestyle changes are really, really hard. And sometimes for some women, for some patients, you truly are doing everything that you can. You are like, I talk to women all the time who are like counting their calories and they're exercising like crazy, and they're still having these challenges. And you can't control everything. And some of it is your genetics, or things that are totally outside of your control. And so sometimes you need help. And so, sometimes that's medication. When I have patients who have these issues and it's concurrent with being above a healthy weight, sometimes doing things like taking weight loss medications or even considering weight loss surgery, because sometimes you're doing everything right and it's just not enough to see the changes you want to see. And so, sometimes it's more than just doing stuff on your own. Next question is from Diana. I'm 42 and will turn 43 in July. I've done blood work and ultrasound. I'm within the normal range for all these tests, but the low end of normal. My partner is on TRT, which is testosterone replacement therapy, and didn't have any sperm when we did sperm analysis. So he's decided to go off of that. From what I know, it can take 3 months and sometimes up to 2 years. But this patient's concerned because of her age, about waiting that long for sperm to come back. So is it possible to freeze the eggs for 6 months until he's able to produce sperm? And then the next question is there a certain concentration of sperm in order to do IVF, or is it sufficient as long as you have some viable sperm? Fabulous questions. And I think you're thinking about all the right things, right? Like, in an ideal world, you would wait until there's sperm that's returned to the ejaculate. But reproductive aging is a progressive process. And so we don't have all the time in the world. So what I would say is, for your partner, it's interesting because sometimes men will go on testosterone because they have a testosterone problem. And so it would be, if that's why he went on, it'd be good to speak with a reproductive urologist, because there may be medications that he could take that are not testosterone, but could boost his testosterone levels and improve and help get sperm back faster for you. But you absolutely could consider something like this where you bank eggs until you have sperm to work with. But to answer your second question, we can do a lot with a very, very little sperm. And I shouldn't say we, what I should say is our embryology teams are incredible. And basically you only need as many good sperm as you have eggs. So even if there's a few in there that you can get access to, that may be enough to fertilize your eggs through IVF. The next one is, what is the process of PGT testing? So PGT testing is done on blastocysts, which are embryos that are in the day 5 to 7 stage. And basically what's done is it's done in the embryology lab. And the reason why we do it at that stage is because we can really tell what are the different parts of the embryo. And there's a part that, we can tell is going to become the embryo or the baby. And there's a part that we can tell that's going to become the placenta. And so we feel that we can safely sample these embryos because we can avoid the part that's going to become the baby. So 3 to 5 cells are taken from the part that's going to become the placenta, and that is what's sent off for genetic testing. And it's an incredible process. The embryologists do this under a microscope. They use microscopic lasers to separate the cells from each other to get a sample. And then we cooperate with specialty labs that actually can amplify that teeny amount of DNA to get enough to get results. So I hope that answered your question. I'm wondering if you might have meant more doing IVF to get embryos and then do testing. But that's the nitty-gritty of the actual testing of embryos. So then the next question is assisted hatching required for an FET cycle, and how exactly is it helpful? Is it harmful to a frozen embryo? Assisted hatching, is something that sometimes we'll do if we're going to do genetic testing of an embryo, but it's not something that's routinely done on all embryos all the time. And so that's something I would talk to your doctor about their specific protocols in their lab and what exactly they use assisted hatching for. But we don't think routinely doing it in all cases is necessarily helpful. The next one is from Deja, and it is, what is a normal sperm count? Great question. So when we do a semen analysis, we look at a lot of different aspects of the sperm. So we look at, how many sperm are there, how many are moving, how many are normally shaped. And there are reference ranges for all of those things. So basically, how they determine those is they took men who had been fertile within a recent period of time and then looked at their sperm and developed sort of a range of what was normal for those men. And so that being said, there are certainly men that can conceive with numbers that are outside of those parameters. But in terms of a normal sperm count, it's normal to have more than 15 million sperm per milliliter of semen. And we like to see that there are over 40% of the sperm are moving. And we also look at how many are normally shaped, and we like to see at least 4% normally shaped. The next question is, if someone is 33 with lean PCOS, and the only issue is anovulatory cycles, what is the recommendation after 3 medicated IUIs, and why would they be failing? Great question. And I find that when I take care of patients with ovulatory issues, it can be really frustrating when your first attempts don't work, because you think, man, if I could just ovulate, it's going to happen for me. And for some women it does, but there could be something else going on. And to your point, that may be something that we can test for, but it may not be something we can test for. And so, I mentioned earlier that sometimes we get to IVF and we don't know why less invasive treatments didn't work. But then IVF does, and it works like a charm. And sometimes people get to IVF and we find that we get a reason why it hasn't been working, like there's a fertilization issue or an embryo development issue that we wouldn't have known about unless we're looking at eggs and sperm outside the body when they're making embryos. And then probably have probably have time for just one more. Thank you so much for all these fabulous questions. Like, these are just great, and I really appreciate everybody writing in and joining me. But so I think this is a great kind of one to end on. It says, I'm awaiting my first ultrasound after an FET, and I have been very anxious after hearing of a few friends that have experienced an embryonic pregnancy. So that's a form of early pregnancy loss. Is there anything that puts someone at higher risk for this, or beta levels that are more associated with this? So great question. So, you know, early pregnancy loss is unfortunately very common. So even when you're young, about 20%, we tell people of pregnancies end in early pregnancy loss. But what that means is that most pregnancies don't result in that. So statistically speaking, I'm really hopeful for you that your ultrasound is going to look great. There are things that put people at higher risk for pregnancy loss, and the biggest one is your age. So especially women who are in their late 30s and especially early 40s are at higher risk. That doesn't mean it's definitely going to happen, just means it's statistically more likely. And in terms of beta levels, you know, really what we look for is the trajectory of the levels and less about an individual number. I've seen beautiful beta levels and then had that patient have a loss. I've seen really, really low beta levels, and that's somebody's beautiful, perfect baby, and it worked out. So it really is about the trend and less about like an individual number. But my advice to you would just be super kind to yourself, because this is a really hard time early in your pregnancy. And I don't know you, but I imagine you've been through a lot to get to this point in your pregnancy. And, you know, nothing that you are doing or not doing is going to make or break this pregnancy. And, you know, it's hard to know that in your heart, but, I know that that's true. And so you just got to be kind to yourself and get through this time that's really hard with all the uncertainty. I have another, well, probably do one more. Next one is a semen analysis result that basically has a normal volume of semen, has a normal concentration and motility of the sperm, but there's a low number of normally shaped sperm. And the question is, you know, can I still get my partner pregnant with these numbers? Absolutely. I mean, there is plenty of sperm there to work with. The morphology number, the percent normally shaped, that's sort of a controversial topic. And some people, sometimes we worry about fertilization with that, but it's entirely possible. If you haven't tried to become pregnant yet, you may have no problem at all. Or if you've been trying and having trouble, you know, there are probably multiple options for treatments that could help you guys. And then I'll do one more if that's okay, because this is a great question. If during initial workup testing, genetic testing on the parents is completed and there's no defect, is there still a possibility that frozen embryos that come from that couple could have genetic issues, or should all the embryos be normal? Fabulous question. So probably you've done something called carrier screening. And if you and your partner both came back negative, you know, that can't entirely eliminate the risk of a genetic problem in a child. Like sometimes mutations come up out of nowhere that like are not in your family and you and your partner don't have. There's also like these tests are not comprehensive. Like they test for, you know, 300 or 400 things, but there's other stuff out there. And then there's also the whole concept of aneuploidy, which is a random mix-up of DNA in the embryo that's not something you can test for before pregnancy. So if you've done carrier screening and you're at a significantly reduced risk, that's really reassuring, but it doesn't eliminate entirely the possibility of a child with genetic challenges. All right. Well, I think we are all set, but thank you so much, everyone, for coming and for your fabulous questions and for spending your evening with me. And hopefully maybe someday I'll get to meet some of you in person. But I hope you have a really good night and just thank you so much.